Hi, I'm Catherine Fowler, an Associate Professor of Radiology from the University of California in San Diego. I'm going to be talking today about bile duct disease, in particular cholangiocarcinoma. By way of background, cholangiocarcinoma is a primary malignancy of bile duct epithelium. That means that it has cholangiocytic differentiation. The majority of these tumors are adenocarcinomas with some rare variants reported. In terms of risk factor, the most of these cases that we see in practice actually occur in quote-unquote normal livers. That is, patients may come in with jaundice or other symptoms and are found to have tumors. These patients are not typically enrolled in any screening or surveillance programs, though there are some risk factors for intrahepatic cholangiocarcinoma that have been recognized, including chronic inflammatory conditions like primary sclerosing cholangitis, liver stones, biliary malformations, basically anything that results in stasis, like Caroli's disease or polycystic liver disease. And of course, there's overlapping risk factors in terms of HCV, HBV, as well as NASH for patients at risk of cholangiocarcinoma and hepatocellular carcinoma. The pathogenesis of these tumors is in fact quite interesting. We have hepatic progenitor cells that, depending at what point they receive a mutation, or a hit, if you will, can differentiate into multiple different types of tumors. We can have progenitor-like HCCs. You can have mixed or biphenotypic hepatocellular cholangiocarcinomas, or you can have cholangiocyte cholangiolocellular carcinomas. If the hit happens here into a mature cholangiocyte, you develop an intrahepatic cholangiocarcinoma. A mature hepatocyte tends to develop into hepatocellular carcinoma, though there is some transdifferentiation between these two. So what does this really mean? It's all very complex, but I think the thing to take home here is that there really is fewer and fewer pure cholangiocarcinomas. With the increasing use of immunohistochemical staining, we're recognizing phenotypic overlap between HCC and intrahepatic cholangiocarcinomas. Here are some of the markers that we can test for on immunohistochemistry. And then we have this area of overlap where some tumors exist. And these include the CK19 positive hepatocellular carcinomas, cholangiolocellular carcinomas, and the biphenotypic tumors. These tend to be bad actors. With regards to pathogenesis, many tumors we think of having precursor lesions. Precursor lesions for cholangiocarcinoma have been identified, and they include the biliary intraepithelial neoplasias. These can be counterparts or considered to be counterparts of the IPMN-like lesions within the pancreas. These may form mucin, and these may have polyps within the lumen of the bile duct. The tumors that arise from these precursor lesions tend to be mucinous tumors. What about adenomas? In colon cancer, tubular or villous adenomas are precursors to colorectal cancer. However, with the bile ducts, that's actually not considered to be true. Bile duct adenomas are a rare lesion, which are not considered to be a precursor lesion. These are truly benign, regenerative types of lesions. And if you ever see them in practice, you'll virtually never get the diagnosis right prospectively. They tend to be solid, solitary, enhancing, somewhat circumscribed nodules. So cholangiocarcinoma is more complex than most tumors. It's really challenging to classify these tumors. There are several ways that this has been attempted. We can divide them as intrahepatic versus extrahepatic. We can divide them based on whether they're involving the small ducts or the large ducts. We can talk about their differentiation and pathology, and we can talk about the growth pattern. And probably from the radiological perspective, the growth pattern is most relevant to us. According to growth pattern, we can classify these tumors by 4 types, and these will be the mass-forming or intrahepatic cholangiocarcinomas, periductal infiltrating tumors, those with intraductal growth, and then combined mass-forming and periductal infiltrating tumors. So let's take a look at examples of each of these. Here's an example of a mass within the liver. We can see a mass within the liver on imaging as well. This is intrahepatic mass-forming cholangiocarcinoma. These tend to arise from the smaller ducts within the liver, and these are going to be a minority of cases that you come across with regards to cholangiocarcinoma. Pathologically, these tumors are comprised of columnar or cuboidal epithelial cells. They are characteristically necrotic centrally and have a lot of fibrosis. They do not have a fibrous capsule, unlike HCCs, so we tend to see a different border around these tumors than we do with hepatocellular carcinoma. How about periductal infiltrating? These are the more classic Klatskin type and extrahepatic tumors that we talk about with cholangiocarcinoma. And these truly do cause ductal stricturing. They can cause vascular occlusion. And as you can see here, the growth pattern along the duct and the vascular tracts is the classic. These tend to be infiltrative. They have also a lot of dense fibrosis and collagen that leads to stricturing and delayed enhancement, and very early invasion of portal structures and perineural invasion, which tends to be a poor prognostic feature of these tumors. These, just to make matters worse, and we'll go over this in more detail later, are further classified based on the location and the ducts involved. The final type that we'll talk about that's its own entity is an intraductal growth or a papillary version. These tend to be the most rare, especially in Western practice. These are intrahepatic larger ducts that are involved, or the extrahepatic ducts, and these are the ones that can arise from those precursor lesions that we talked about. So here you can see duct, and you can see there's tumor growing within and expanding the lumen of the duct. Here's another example on ERCP, kind of a polyploid mass-like filling defect within this duct. So, as I mentioned, we tend to classify tumors, cholangiocarcinomas, by their growth pattern. Mass forming, periductal infiltrating, giving us the strictures and the Klatskin tumors, and intraductal or papillary growth patterns. How about tumor markers? We know with hepatocellular carcinoma that AFP is a very common tumor marker. With cholangiocarcinoma, it's CA19-9. This is expressed in pancreas, bile ducts, gastric, and colonic epithelial cells. So it can be elevated truly in any of those cancers, but it's thought most commonly to be elevated in the setting of pancreatic and cholangiocarcinomas. Up to 10% of the population lacks the ability to create this blood group antigen, and hence some patients are basically non-secretors. With this in mind, the sensitivity of an elevated CA19-9 is about 72%. It's much more helpful if it is elevated than it's concerning for the diagnosis. If it's not elevated, then you don't know if there's concern for the diagnosis or if the patient potentially doesn't form the antigen. Of course, in patients that have higher background levels due to inflammation, such as patients with PSC, you need a higher threshold for positivity. Making the diagnosis of cholangiocarcinoma can be challenging. Pathological diagnosis is often needed prior to initiation of chemotherapy or radiation therapy. Typically, we'll get on an FNA an adenocarcinoma not otherwise specified result from cytology. In this case, we're needing to correlate with tumor markers, immunohistochemistry, and potentially search for a primary. Because as you know, adenocarcinoma can arise from virtually anywhere, and periductal metastatic disease is not entirely uncommon in some disease processes like breast cancer. Hilar cholangiocarcinomas can be particularly difficult to definitively diagnose. If they're amenable to surgical resection, we don't necessarily need to make the diagnosis up front, because if they have a malignant appearing stricture, the surgeons will take them to surgery. But if we look at what we can do, ERCP and brushings, the yield's only about 40% on making that diagnosis. They can do FISH, and the sensitivity is quite low, but if it's positive, it can be very helpful. EUS and FNA are options if they have a mass or if there are nodes that are enlarged. However, we need to be careful if patients are potentially amenable to surgery because this can lead to peritoneal seeding. When we look at the accuracy of the preoperative clinical diagnosis of cholangiocarcinoma, it tends to be fairly accurate. And what do I mean by that? That means that we've got a tumor that looks like a cholangio, and we've got elevated tumor markers or a clinical presentation that fits. So let's look at some of the imaging features. We talked about the growth pattern pathologically, we talked about the tumor markers. Now let's refer back to our imaging. And this is just kind of an overview of what we're going to talk about. With regards to the mass-forming cholangiocarcinomas, as these patients are not enrolled in surveillance or screening programs, these masses tend to be large at the time of detection. We talked about them lacking a capsule. They tend to have ill-defined or lobular margins. Multicentricity or satellite lesions is a common feature, and oftentimes you'll see biliary duct dilation peripheral to these lesions. Capsular retraction is also something we commonly see, and that goes back to the fact that these tend to be very fibrotic tumors and cause volume loss over time as fibrosis increases. On T2 weighted images on MR, they tend to have heterogeneous or almost somewhat targetoid appearance, sometimes having dark signal centrally. Targetoid enhancement is one of the classic features described by LI-RADS for the LRM category. LRM is sensitive for malignancy, but not specific for HCC. So it's really meant to capture the non-HCC malignancies that can occur in the liver. Targetoid enhancement is defined as rim, arterial phase hyperenhancement, central delayed enhancement, and peripheral washout. So that same area that showed rim enhancement early on demonstrates washout on the later extracellular phases. One important point to make is that not all peripheral enhancement is rim enhancement. Sometimes we may have compression of adjacent parenchyma. In this case, though, we can see a large mass clearly replacing liver, very malignant appearing, and it's accumulating contrast over time. So this would still meet one of the features of the targetoid enhancement. Other features of LRM include targetoid diffusion-weighted imaging and targetoid hepatobiliary phase appearance. Here are some examples. This is a diffusion-weighted image of bright signal peripherally with the corresponding ADC map demonstrating dark signal peripherally. Here, there's this cloud-like central enhancement with a peripheral rim of dark signal on the hepatobiliary phase. Here's just another example. These are the targetoid appearances. So here's a case. 72-year-old woman comes in, solitary liver mass, no history of liver disease. So if we look at our features, it has somewhat of a peripheral or a rim arterial phase hyperenhancement, and we can see that it's progressively accumulating contrast. This would not be a good look for hepatocellular carcinoma, but this could easily be cholangiocarcinoma or metastatic disease. So as I mentioned, there are overlapping risk factors with HCC and cholangiocarcinoma. Increasingly, we're seeing these tumors in patients with hepatitis B viral infection and hepatitis C viral infection. As such, it's very important to differentiate non-HCC malignancy from HCC. Just to take a very brief divergence here, HCC, as we know in the United States, is primarily going to be treated with resection or transplantation. Transplantation allows for the imaging diagnosis alone and no need for histopathology to prove the underlying diagnosis. So patients with early-stage HCC can undergo transplantation and be cured. Patients with cholangiocarcinoma have very high recurrence rates following transplantation, and transplant is not considered a first-line therapy for them. Hence, it's really quite important to differentiate these two tumor types. So as I mentioned, LI-RADS provides specific criteria in the form of the LRM category. They also suggest that when in doubt, in patients with risk factors for HCC, between an LR5 and an LRM, you're going to tie break down to an LRM. So we already went over a lot of these features of targetoid appearance, but this is just again to kind of reiterate that these features are thought to reflect the peripheral hypercellularity and the central stromal fibrosis or ischemia that we tend to see in patients with intrahepatic cholangiocarcinomas. The appearance is virtually identical with metastatic disease from an adenocarcinoma primary. So here's an example of a patient with cirrhosis that has a very large and malignant appearing mass. A little difficult to characterize this arterial phase hyperenhancement pattern, but clearly this demonstrates accumulation, delayed central enhancement, and peripheral washout. If we look at our diffusion, the quality is not great, but we can somewhat perceive a targetoid appearance. So this is a very good look for an LRM tumor. So where do these LRM criteria come from? Basically, they're best available evidence and expert consensus. So the best available evidence we have is in the form of multiple retrospective single-center studies. These primarily were looking at comparing atypical HCC and intrahepatic cholangiocarcinoma. Of note, not all the patients included in these studies were in fact quote-unquote at risk according to LI-RADS. Peripheral or rim AFI was in fact the most common feature of ICC, and central progressive enhancement was just a little bit behind that. Of note, the smaller the tumor, the less likely it is to show that targetoid pattern, and that's because it's had less time and it doesn't have as much substance to show the central desmoplasia and fibrosis that causes the appearance. There are a few cases reported where we've seen washout, and capsule has exceedingly rarely been reported, but has been shown to be present in very small ICCs. So you can imagine these small tumors might be challenging to differentiate from HCC. And then there's the question, do intrahepatic cholangiocarcinomas that arise in a cirrhotic liver differ in appearance from those in non-cirrhotic livers? And in fact, there are some authors who suggest that tumors arising in cirrhosis may in fact be more hypervascularized and may be more prone to demonstrating washout and mimicking HCC. I just want to share with you a relatively rare case. Here's a pre-contrast arterial phase, portal venous phase, a T2. And as you can see, this tumor is demonstrating arterial phase hyperenhancement fairly convincingly, non-rim, demonstrates washout, restricted diffusion, T2 hyperintensity. Here's a gadoxetate disodium hepatobiliary phase showing hypointensity there. This is the pathology, and this is in fact one of those rare variants where by imaging it looks like HCC, by pathology it's a cholangiocarcinoma. So as I mentioned, these small tumors can sometimes mimic HCC. So what about tumor in vein? We traditionally considered this finding to be highly suggestive of HCC. However, cholangiocarcinoma and biophenotypics in several studies have been shown to invade the portal or hepatic veins as well. So let's switch gears here and talk a little bit about intraductal or papillary carcinomas. So here are a couple of the cases I showed you earlier. And here you can see this tumor is basically following a tubular structure. You've got peripheral ducts dilated out beyond it. And on the T2, you can see it's pretty much confined within. I want you to notice the smooth margins associated with this. This doesn't have that infiltrative appearance I showed you with the mass-forming cholangiocarcinomas. Here you can see again, tumor within the duct. Here's yet another example. You can see this tumor is enhancing and filling that duct. And here you can see a little bit of it here extending into the duct, a little more of it. So these tend to have smooth borders and enhance. Periductal infiltrating tumors, these tend to arise in the setting of PSC or other abnormalities. These are going to show up with multifocal strictures, and then the tumor, if it arises, will cause a new dominant stricture. So that's what you're looking for if you're performing surveillance imaging on these patients. You're looking for a new dominant stricture. The most common location of these tends to be within the hilar region, the Klatskin tumors. The second most common location tends to be distally near the pancreatic head or ampulla. If you see a mid-duct malignant stricture on ERCP or MRCP, you need to start thinking if this could be a gallbladder carcinoma, because that actually tends to be more common in the mid-duct than cholangiocarcinoma. And the reason for that is that gallbladder carcinoma can grow down the cystic duct insertion and cause a mid-duct stricture. So here's an example. MRCP, we've got these ducts that do not come together. So you've got a mass that's basically separating all of these ducts. This is kind of a mixed type. You've got this stricture here and a mass-forming component. Here you've got more of an infiltrative appearance. Here's an example within the liver where you've got ductal thickening and stricturing. So as I mentioned, these tumors can be further classified by their involvement of specific ducts. The bismuth correlate classification is probably the most commonly used for surgical resection purposes, and that basically goes from 1 to 1 to 4, 4 being extension to the secondary branches on both sides. Other classifications exist, though this one, the TNM, AJCC, tends to be more of a post-operative system to help link outcomes. Memorial Sloan Kettering has a system to predict resectability, and this takes into account some additional features and tends to be somewhat subjective, though has been shown in some large series to be relatively accurate. Mayo classification is another one. This is a little bit more clinical as it takes things into consideration like the ECOG performance status and the presence of metastatic disease, lobar atrophy. I'm just kind of showing you these several different classifications so you can be aware of them. I don't think it's important for anyone to memorize these. So let's just go over a case here, just to show you the complexity of this in practice. This is a 65-year-old woman with jaundice. She's got this tumor here. You can see she's got ductal obstruction. So what we're going to do is basically look at her ducts in reformats and see, do her right anterior and posterior ducts actually come together to form a right hepatic duct? Does her medial and her lateral section duct come together? And you can see here it does. So it's not involving her left hepatic duct, but it does extend up to the secondary branches on the right. This would be a bismuth 3A. Now if we look at the same patient and we look at her tumor in relation to her arteries, because of course when you're talking about resectability, it's not just the bile ducts. You also have to know if there's arterial and portal venous invasion. So here's tumor and here's right hepatic artery, and you can see that it's basically encased, greater than 180 degrees. And here's your right portal vein, also abutted by tumor. The same case, another important thing to think about is whether or not there's lymph node metastatic disease. So this patient, in fact, has a very enlarged lymph node. She also has pancreatitis from her ERCP, so we can kind of ignore that. But the lymph node needs to be biopsied before they consider any resection. And then the final thing to think about is whether or not, based on the resection, she has right hepatic artery, right portal vein involvement. So perhaps they could do a right hemihepatectomy. So the next thing we have to know is, does she have sufficient volume to support the surgical procedure? So for there, we're going to try to calculate what's called the FLR, or functional liver remnant, and that's basically going to be what your remnant or your residual liver will be divided by the total liver. So here's another example of a tumor. This one is a periductal infiltrating plus mass forming. This is a dilated duct here. You can see a little bit of your left portal vein. So when you have periductal infiltrating with a mass, that tends to indicate more advanced disease. Here's a relatively rare intrahepatic variant of periductal infiltrating. So we had a new dominant stricture on our MRCP, and we can see here that we've taken out our portal vein. So that's another factor. When you're looking at the post-contrast images and surveillance, if you lose a portal vein, that's another sign that there could be a tumor there. Here's an example. We have a tumor. We've got basically a Klatskin variant. And if we look at its involvement with the arteries, soft tissues encasing the hepatic artery, there's your little bright dot of hepatic artery, and here's tissue basically encasing it. This tends to be unresectable disease. Here's an intrahepatic mass. We've got atrophy associated with it. Her left side looks okay, left hepatic artery and left portal vein. This could be amenable to a right hemihepatectomy. So I just want to present a couple of those cases so you can see how we go about thinking about what the management is of these patients and why it's important to dictate about the arterial, portal venous, and biliary involvement. And really the main reason is that the only chance for cure that these patients have, and really the only chance of survival, is through surgical resection. Resectability is going to determine their outcome primarily. Unfortunately, it's only an option up front for a very small number of patients, about 30%. And even of those at exploration, almost half are deemed to be non-resectable. The 5-year survival rate of 20 to 40% is really limited by regional metastasis. But if we look at patients who have an R0 resection versus those who do not, the survival is much greater for those who can achieve an R0 or a complete microscopic resection of disease. There are other options for these patients, though not available at very many centers, but there are some transplantation protocols. Most centers that do transplantation for cholangiocarcinoma are going to follow what's called the Mayo protocol, and it's really a rigorous system of neoadjuvant chemotherapy, staging laparoscopy, and then a very selective enrollment, basically tumors that are quite small. We don't want to have very elevated CA19-9. You want them to be functionally okay with regards to their liver, and they can't have had a transperitoneal biopsy for the risk of seeding. If they meet all these criteria and can make it through the 6-month protocol, they tend to have a pretty good recurrence-free survival. So I'm going to end the talk here.